it's really great to be here to talk to you about Purpose T eventually. So this is the plan for this webinar. So I'm going to give you a little bit of background about risk assessment, and then I'm going to hand you over to Jane to talk about Purpose T development and the research that we did in the development of Purpose T, because I think it's important for you to understand that we, put a lot of effort into this to trying to design and develop a tool that was going to be evidence-based and useful in clinical practice. And then I'm going to just talk a little bit about Purpose T and the ongoing evaluation and the implementation so far. So risk assessment, I probably don't need to tell you all this, but it's still a challenge identifying which patients are at risk and how to identify them. There are usually multiple risk factors, and which risk factors are most important. There's a lot of different tools out there, and they've all got different risk factors that they include. So it is a tricky area of practice. And if I look at international guidance, what it says about risk assessment is that they should conduct a screening as soon as possible after admission to the care service, and then periodically thereafter to identify individuals at risk or potentially at risk, and then conduct a full risk assessment as guided by the screening outcome, and develop and implement a risk-based prevention plan for individuals at high risk. And when conducting a risk assessment, you should use a structured approach, and it should include a comprehensive skin assessment. And we should supplement the use of the risk assessment tool with additional risk factors and the use of clinical judgment. Now, this is something that a lot of people, there's been a lot of debate about, but actually it is something that we really do need to integrate. These tools should really only be an aid memoir to help and assist us in identifying those people who are at risk. So a few years ago, actually in about 2009, Jane Nixon, who was the chief investigator of the Purpose programme of research, which was a £2.2 million piece of research, she got the money together really from the NIHR for us to be able to undertake this research and to develop a new risk assessment tool, because we felt that the ones that were already in existence had been there, the evidence base underpinning them was not great, but they were a good starting point, but actually we felt that we could use the evidence that had been developed to develop a more robust tool. And so I'm going to hand over to Jane now, who's going to take you through the actual research methods for the development of Purpose T.
Hi, everybody. So I'm slightly conscious of the fact that some of you are already using the Purpose T, and for some of you it may be new. So we're not going to dwell on the methods, but I think what we're trying to get across to you all is that the approach that we used, it's not perfect, but it's what we're trying to use is the best available evidence, and the best minds, so to speak, from across the world in developing the Purpose T. So as Susanne's alluded to, I don't know if can people see my mouse or not? You're on mute.
No, Jane, they won't be able to because it's from my screen.
All right. Okay. So okay. First of all, we did a systematic review to identify factors that were most predictive of pressure ulcer development. Then that informed a consensus study that was international and some consensus work with service users, which identified the risk factors that were considered to be most important in identifying people who were at risk. We then developed that into a conceptual causal pathway, a theoretical causal pathway, to try and understand how many factors that potentially contribute to risk, which we use in clinical judgment all of the time, how they actually fit together and how we can make sense of them in a structured way. Then obviously we designed the purpose T, and then we did some evaluation work. So I'm going to run through the evidence and the methods, as Susanne said. Oh, next slide, please. So the systematic review question was which risk factors are independently predictive of pressure ulcer development. And by independent, we mean something that has a statistical association that's retained when you put lots of factors in to a statistical model. So that's the key thing. It's so, for example, mobility might knock out something like incontinence, because you're more likely to be incontinent if you're also immobile. So it's trying to understand what the different associations are between the two risk factors and which ones are actually the dominant ones. Next slide, please. So we had 250 variables. We listed a number of domains. And the key ones that we identified in terms of the strongest statistical evidence were immobility, skin status, and perfusion. Next slide, please. And when we then looked at, we did a review of the risk assessment tools that were in the 2014 NICE guidelines, and only 5 of the 14 risk assessment tools included skin condition, and only 5 included anything to do with skin perfusion. And so that was our justification for doing something new. Next slide, please. As I've said, there was an international expert group, Janet Cudingham, various others from the US, from Europe. We didn't have Pan-Pacific people, but a mixture of engineers, nurses, epidemiologists, surgeons, and so forth. So next slide, please. And so we in the consensus process, so we had 3 meetings overall. The first thing we did was reduce this massive number of 250 different variables that were cited in the literature, which we'd included in 15 risk factor domains and 46 subdomains. And with each consecutive cycle, we reduced that number down to 7. So immobility and skin status were the 2 key factors considered important by the group or as part of the process. And then the other areas included perfusion, diabetes, sensory perception. Obviously, diabetes affects both perfusion and sensory perception, moisture, nutrition, and we added in pain. So next slide, please. And then we tried to put, as I say, all of those into a theoretical causal pathway. So if you look to the left of your screen, you'll see that older age is a risk factor that's, or age has emerged in risk factor research as being important. In some studies, it's come out as an important predictor. But if you then follow the dotted line, you can see that older age, if you go up, affects immobility. Older age affects skin status, and it also impacts potentially on comorbid disease, which affects perfusion. And so we were able to put together the 250 different variables into this sort of pathway, where if you look at the right of the screen, so the orange diamonds, if you like, are direct causal factors. So they're the 3 factors that were most heavily associated statistically with pressure ulcer development, the outcome, which is red. But if you work backwards, you can see that the indirect causal factors and the other potential causal factors all sort of impact on those 3 direct causal factors. Next slide, please. And then that was applied to or linked back to the what the engineers talk about, which is biomechanical or mechanical boundary conditions. So the magnitude of the load, the duration of the load, and the type of load, and the susceptibility of the individuals. So properties of the skin, geometry of the tissues and bones, and so forth. And those factors then in turn impact on internal stress, strains, transport, and affect individual damage thresholds and lead to pressure ulcers in some individuals. And the reason that we struggle to identify people at risk is because of all of the different factors involved. Next slide, please. So that was then reworked into a clinical framework with the mechanical boundary conditions on the left, which is impacted by immobility and potentially sensory perception and response. And then on the right is the individual susceptibility and tolerance, and that's impacted by skin status, diffusion, nutrition, diabetes, moisture, and potentially low albumin, and generally illness. Next slide, please. Oh, what's happened to, oh. So we then converted that into a draft purpose T, and there was, we undertook a pre-test. We looked at usability, acceptability, content validity with nurses. We did some pre-testing, cognitive pre-testing sessions in focus groups and one-to-one think aloud. We used vignettes, and then we we then improved the formatting of the purpose T. Next slide, please. We then did some clinical evaluation with over 200 patients, where we looked at the inter-rater and test-retest reliability, which was found to be very, very good. And we also compared it to other risk assessment tools, and there was high associations. So there's been a question about what's a vignette. So that's basically like a mini case study. So when we did the focus work group, we asked the participants to review the case studies and to complete the purpose T using the information from the case studies. And yeah, so we could have called them case studies, we called them vignettes. It's a research term, I think. Next slide, please. And then we developed, that then led to the purpose T, which is, as indicated already by Jackie, is freely available. This is version 2. Are you taking over now, Susanne?
Yeah, I'll take over if that's okay. So yeah, so the key features of purpose T, I'm going to go into a little bit more detail, so bear with me now for those of you who already are using it, but obviously we're hoping that people who aren't using it can have a better understanding as well. So the key features are that it incorporates a screening stage, a full assessment stage, and a stratification stage, and you can see that it's very colourful. And so we moved away from the scoring systems that have been traditionally used, so that really we could look at like what the profile of risk was for a patient, and so we weighted risk factors according to how much significance that they were felt to have on pressure ulcer development, and this all links back to that conceptual theoretical schema that you saw. So at the end of it, they would, if a red box or pink box was ticked, then they had an existing pressure ulcer. And if they had no red ones but an orange one ticked, then they're at risk. And then if it was green or blue, then you need to make a decision about whether or not you think they're at risk. And I'm just going to take you into a little bit more detail about that now. I'm going to try to anyway. Now my screen has jammed now for some reason. I'm not having a lot of luck, am I, with this? So just to give you an overview then of the differences, the screening stage is different, and in that so you could screen all patients quickly, and hopefully screen out people who are not at risk, and hopefully this would save time in practice. So instead of doing a full Braden or full Waterloo, which is time consuming, you would be able to screen out some patients. And then we also wanted it to support care planning in response to the patient's risk profile rather than a condensed score. So I'm sure you'll have all experienced where you've got two patients with the same score, but actually they've got a completely different set of issues, which means that the care planning probably needs to be different. So we use colour instead to support decision making, and we also incorporated the skin and pressure ulcer status, because sometimes you could get people where it might say they're not at risk, but actually they had a pressure ulcer, and that has happened and was something that we observed in some of the research that we've done. So we wanted to use the skin status to really identify that, because obviously if you've got someone with a pressure ulcer, then you're going to need to escalate your interventions. So it makes a distinction between those two groups. So the ones who are at risk without a pressure ulcer, and then the ones who actually do have a pressure ulcer. And also it incorporates like a minimum data set, which we might be able to use for future modelling. So a little bit more detail now about the screening step. You can see that it incorporates mobility status and skin status. And basically, I mean, I'm not going to go into the wording of them all, but you can see that for the mobility status, we're looking at whether or not this patient's got any mobility limitations, and we spent a long time thinking about the wording to make sure that we captured this. So if you ticked any yellow box for the first for the mobility section, you would automatically go down to step 2. But if you tick the box at the bottom, which is the blue box, which is where the patient walks independently with or without walking aids, you'd move over to the skin status box. And here you would look at whether they've got an existing pressure ulcer, whether they've got a history of pressure ulcers, or whether they've got vulnerable skin. And you'd also consider whether or not you were using medical devices which might cause pressure. So again, at the bottom, you've got like the normal skin. So again, if it was normal, you would move across to the clinical judgment element. If you identified a pink box or a yellow box, you would go straight down to the full assessment. So assuming that we've got the walking independently and they've got normal skin, you would then move over to clinical judgment. And this was something that we added in because we really recognised the need for nurses to be able to use their clinical judgment and encourage them to use their clinical judgment. And if they've got any knowledge of any condition that might put them at risk, or the trajectory of the care, if you've got someone who's at end of life or whatever, and you're expecting them to deteriorate quite rapidly, then, you know, that's something that you would want to consider, and you might want to do a full assessment. But if there's no problem with that, then you would be able to move across to the no pressure ulcer, not currently at risk, and screen them out. So if you've ticked any of the yellow boxes or the orange boxes, you would then move on to the full assessment. And here you can see there's the analysis of independent movement, and this is probably the most complicated item on the on-purpose T. And I think what we found in pre-testing is at first people are like, oh blimey, what's this type thing? But I think you just need to do it a couple of times, and then most people are happy with it. So when we think about movement, we're talking about independent movement. And the two factors that are really important are the extent of independent movement. So basically, are they actually relieving all the pressure areas, or is it just a slight movement where probably they're not completely offloading the pressure? And then also the frequency of the position changes. So, you know, are they just doing this every now and again, or are they moving consistently and all the time? And as it's like a matrix, you would plot that. So somebody might move frequently and make major position changes, and there would be a yellow, and then the others fall into the amber category. And then we've got sensory perception and response. I'm not going to go through all of them in detail, but there's a couple that are more probably complicated than others. And with the sensory perception and response thing, this is around patients who, so are they unable to feel and or respond appropriately to pressure? So we know that there are two factors there. Some people can't feel and so are not going to respond. And so I'm thinking about people with neuropathy, that type of thing. And some people can feel but can't move. So, you know, there's a few factors there that you need to consider. And you would tick the appropriate box. And then there's the moisture one, which I think is self-explanatory, the diabetes one. Perfusion, again, we've looked at the evidence around perfusions. There's more work to be done from a research perspective there. So we identified that there was something around conditions that affect central circulation. So if they've not got a blood pressure, or it's, you know, they're in shock or whatever, really hypotensive, or if they've got some peripheral sort of vascular problems. And again, the nutrition ones are relatively straightforward. The medical device one's straightforward. And then the current detailed skin assessment notes the key sort of skin sites that are usually an issue in pressure ulcers. But there are also some other, you know, we do have patients who might have contractures or whatever and develop pressure ulcers in different or unusual places. So there's some empty boxes there for you to add to that in the current detailed skin assessment section. In the skin assessment section, sorry, we would look at whether or not there's any pain at a skin site, and also whether there's any vulnerable skin, or whether there's a pressure ulcer, or whether the skin's normal. And we do that for each skin site. And then also there's there's the previous pressure ulcer site, and whether, because sometimes people can have scarring due to that, and that leads to an ongoing vulnerability in that area. So as I mentioned earlier, by looking back at the assessment that you've done, if you've ticked any pink boxes, then obviously they've got a pressure ulcer already. You would also have the profile of the risk, so that would help you to plan the care accordingly. If there's no pink boxes ticked but some orange boxes ticked, then they would be at risk of pressure ulcers. And there are some patients who fall into who only have yellow boxes and blue boxes ticked. And then you've really got to consider and use your clinical judgment around that risk profile to decide whether or not they're currently at risk. So that's kind of the main things around Purpose T. We have a registration system for you to be able to register to freely use Purpose T. And the slides, you'll have access to that. Basically, you fill in a form. It's really quick. It's like a 2-minute job. It's your name, your details, what organisation, what you're wanting to use them for, and it tells you a little bit about Purpose T and all the publications that are related to it. And then you send an email, like a permission to use email, with the information that you'd require to actually start implementing it in practice. And the things that we provide in that automatic email are, we provide obviously a copy of Purpose T. We provide a user manual, which is really useful for training, because it really drills down. I mean, I've skimmed over it today, but it really drills down about what each item of the tool means and how you should assess that each factor. And then we've also got some presentation material that can be used when you're actually doing your training around purpose T. And we've got some case studies as well that can be used in the training of individuals. And there's also some sample care plans which can be drawn from to, obviously we understand that people have different documentation. So we developed that just as a bit of a prompt and for people to think about and to adapt according to their needs. So in terms of the implementation in practice, since 2014, when it was launched, we've probably had over 1,000 now actually to permission to use requests. And we've had a lot of organisations that are fully and partially implemented. I did do a survey, you can see the list here, but I suspect it's much greater than this now. What happens is when we send them the stuff, we get everybody's name on record, but sometimes people, you'll all be aware that sometimes there's a better time to implement than others, and sometimes they get all the information, but they don't implement for a year or two. And sometimes I don't actually hear from people about whether they've actually implemented. Sometimes I do, and I've got a bit of a log where I keep that information. But sometimes I come across people who are using it, and I wasn't aware of it. So it's been encoded into at least 4 electronic NHS systems, including System 1, EMIS, and PPM Evolve. By 8 NHS trusts, and there's more of them as well now. It's been translated into and evaluated in Sweden. So there's some work. So Lisa Hulton has done some work around that in the Swedish context, and she's done some papers which are interesting to read as well about the implementation of Purpose T. It's been translated into Mandarin. It's been translated into Turkish, and I think it's being translated into Portuguese as well. So it's getting, we were at the EPUAP conference, and it's getting quite a lot of attention now internationally as well. And so in terms of outcomes, this is the tricky bit really, because there needs to be more work done on the actual outcomes. But we've had reports from early adopters of Purpose T who've reported positive outcomes for example, in consecutive annual prevalence studies in a large teaching hospital. They found a sustained reduction in category 1 pressure ulcers. But I always add a note of caution here, because also they did, most places have done a lot of different educational activities and that, and so and integrated into their electronic systems. So it's difficult to pick out which bits have been really important in that implementation process. But certainly there seems to have been an improved proportion of patients assessed on admission, and improved proportion of those at risk with a care plan. So there's something about prompting those processes of care. Another acute trust indicated that they got a 37% reduction in hospital-acquired category 2 from pre to post-op, but ultimately we do need to look at more robust research that looks at care processes and outcomes, and that is ongoing work. It's problematic because traditionally the methods have involved predictive validity testing, but there's problems with that, because actually you could find yourself in a situation where a tool that has prompted you to put in the good interventions and therefore prevented a pressure ulcer could look like it's performing badly, when actually those prompts are what you want there to actually change the outcome for that patient. And then there's been lots of problems with the few clinical trials that have been done because of various different biases. So I think there's been a failure really to consider risk assessment instruments as a complex intervention, and the delivery contains several interacting components. So it's not just about undertaking the assessment. As I'm sure you're all aware, we can all assess patients, but if we don't actually do anything with that, and we don't put the care in place, and the mattresses and the repositioning schedules and the constant monitoring of skin, then it's not going to prevent anybody from getting a pressure ulcer. So that's still really key to the implementation of any risk assessment instrument. And so I've undertaken some more work to try and understand how purpose T works in clinical practice and what impact it has on care processes. And I presented some of that early work of that and my early analysis of that at EPUAP a few weeks ago. And really, it's about so purpose T is like really a resource to nurses, and it's how they interact with that and what that allows them and facilitates, if you like, in care. So does it prompt them to do something does it prompt them to make sure that the mattresses are in place and things like that, or the communication, does it improve communication? And the work for that is I'm still completing the analysis, but there'll be a paper around that once it's done. And then just to mention the publications that we did publish each step of the development process for Purpose T. And I know that when people are wanting to make a change in their risk assessment, it's often quite important, and particularly earlier in the early implementers, sorry, it was really important for them to be able to show what went into the development. So I've just put the publications there so you can clearly access those. And also we do need to acknowledge that this work was funded by the NIHR, but I think that's all I've got to say really about Purpose T, and I'm happy to answer any questions. I'm sorry if you've been in the chat, but I haven't been able to access the chat while the presentation mode's been on, so I've not seen any of the chat.
Susanne, I've been answering.
All right, oh, that's good.
Jane and I have been answering, and okay. I've got lots of questions written down.
Right.
Okay. So thank you, really helpful presentation, and we appreciate, I think that there's a lot more effort gone into that little brief overview of the research that Jane gave. We understand how much more there was behind that. And quite a few questions cropped up during the presentation, Susanne. Some of them I'm sure you've heard many times before. The first one was a question about the paediatric version. Is that equally well validated? Do you want to say a little bit about that?
Yeah, so when we developed Purpose T, it was developed in adult populations, and LTHT wanted to use, so that's Leeds Teaching Hospitals, really wanted to use it for the paediatric population. It's really difficult because we don't have that much research, if any, around or risk factor research around paediatric patients for us to be able to develop a tool. So they actually adapted the tool from Purpose T and used it in clinical practice. So it's very much based on the original version, but has been adapted, I suppose, for usability to the paediatric population. So it's not been evaluated as in it's gone through a formal evaluation study like the adult version. But given that the evidence that we've got for the adult version is, that's been validated. And then the paediatric nurses and the tissue viability nurses were involved in adapting that and looking at, so building on the sort of key principles and the key risk factors, but making them more user-friendly to the paediatric population. So things like height and weight, it's got centiles, and another issue that they raised was the medical device issue, which can be really a tricky and complex problem in like neonates and things like that. So that's all in there as well. So it's very much based on the adult version, but adapted to that area.
Thanks, Susanne. Gillian's asking, is there a template for the care plans for green, amber and red?
No, so we did think about doing that, and but what we recognised early on was that everybody's documentation is slightly different, and people use different, and we wanted people to be able to localise that to their own policies and procedures. So we recognised that people use different mattresses, different and have different paperwork to support care planning and things like that. So we haven't done that. We've left that for people to do locally. And some people use it with S-skin, you know, and other people have got different ways in which they've implemented it and have developed their own care plans. So there's a mixture of things that's happened in practice.
I think it kind of links to, there was a question quite near the beginning about if you tick in the screening section, if you tick that red box that says, yes, the patient's already got a pressure ulcer, could you jump straight away down to red? And I replied, and you know, it was my decision, Suzanne, so you can tell me if I'm completely wrong, that personally I would say, no, you proceed through the assessment, because in doing the assessment, what you're doing is identifying the risk factors. So if you're then developing a care plan, you should be picking those up. Is that what you would think?
Yeah, exactly. Exactly. Yeah.
There was a couple of questions about skin status and dark skin. So I noticed that you've still got the typical EPUAP thing that says about redness in skin. Do you plan to amend that?
So within the new guidance, there is a section within the EPUAP guidance. There is a section on darker skin pigmentation. So what's in Purpose T is basically just a shortened version of the EPUAP classification system. And it's really difficult. What's really difficult when you develop a tool like this, particularly when we developed it for paper use and we needed to get it on one side, is just the number of, basically, practically, how can we fit everything in? But actually what we did do in that section is, again, at the time that we implemented initially, there were some differences around. We've obviously, you're aware of the work that we've done around trying to get some sort of standardization in terms of categorization between organizations. And so at the time, though, we left that section to be editable so that people could edit to their local policy. So there's no reason why people can't put in something around darker skin, you know, pigmentation and all the rest of it. It's just not something that we've done, because I guess the skin assessment side of it is I've just taken that really from EPUAP guidance. So it's not actually part of the tool, but it's there to be for clinical utility and usability, really, to help people recognise the different factors. So yeah, I mean, this is version 2 of Purpose T, and I think when we review it again, which we're probably likely to do in the next few years, I can't see from the risk factor evidence that there'd be any major changes, by the way, but I can see little things like that we might sort of reference them to the user manual and make some changes to that, and you know, make some reference to darker skin.
And there's an associated question from Fiona Butler about, you've got unstageable but not DTI.
Yeah, and that is because it's editable, and at the time people were not using all the classifications, but there is no reason why you can't put that in, and you should put it in according to what our national policy now is. So we could make that change, I guess, if that would make things easier for people.
And I think, just to say, for those of you in England, there are going to be some changes coming out in the new National Wound Care Strategy recommendations around categorisation. So I would hang fire on doing anything immediately until those recommendations are out. They will be going out for consultation with our stakeholders, hopefully within the next six weeks or so. Yeah. There was a question about costs, Suzanne, and I was tempted to jump in, and I thought I'd just check. Is there any cost implication for the registration and use of this tool for private care homes?
No.
So very importantly, it's free for everybody to use. And is that free in the UK or is that free internationally?
It's free in the UK. The only thing that we put on in the thing is when industry use it for you know, different things, but it's not occurred actually that yet. So no, it's free to use in the UK. And in terms of overseas, we've got some arrangements with like America. America is starting to use it, and it depends how it's being used. But certainly in the UK, it's not an issue, and it can be used That's why we developed it. It was developed by, the NIHR fund is basically NHS research funding. So we don't want to double charge people, and we don't see any benefit really as patients move through the care pathways to nursing homes. We want them to be able to use it so that hopefully we can improve processes of care and better patient outcomes. So yeah.
One of the other things to say around that, Susanne, was I know when I was working in a university, it was free to use in education as well. The benefit of this is that it's out there to help improve the care of patients and to improve clinicians' knowledge.
Yeah.
There's been a question about use by AHPs. I'm just trying to scroll back. So has there been much feedback as to whether the AHP services, particularly people like podiatrists, have been using Purpose T successfully?
Yeah, so I mean, when we did the evaluation, we used nurses because obviously they're the primary group. But actually, I'm aware that there are some other professions who are used, so allied health professionals who are, and there's no reason why, given they just need to have some knowledge and understanding of the tool. Most people find it relatively easy to use because we did spend such a long time on the wording, so it's not as open to interpretation perhaps as some of the other ones out there. I know that it's been used by podiatrists and it's helped in some ways to click on for diabetic foot ulcers and things. It's been used to sort of make a more streamlined process for the assessment of feet and things like that as well. So yeah, so there's no reason why they can't use it if they know what they're doing and they've been adequately trained. It's not rocket science, I don't think. I know that there are some healthcare assistants that have looked at using it as well, but again, it's about what their understanding is, and sometimes as well, people have done different things with, like in some of the really acute places where they've done a top level screening and then the full assessment's been done in the different department, in a different department. So there's been all sorts of different ways to implement it, and that obviously some of that depends on the local context.
And I think that was a question I was asked by a clinical colleague earlier in the week about, do you have to do the screening? So if somebody's an inpatient in hospital, if they're using Waterloo or Braden or another tool, we just do a full risk assessment. With Purpose T, would you expect them to do screening, or could you do almost like a patient group directive that says if somebody's in an inpatient bed and expected to stay overnight, we assume that we're going to proceed straight to full assessment?
Yeah, so this is an
just to reduce duplication. Yeah,
this is interesting actually, but I think the thing to mention here, so I thought about this because in the work that I've been doing, I looked at like a ward, I looked at ward environments where the level of risk was variable, where you did have young fit people in, and then I looked at like an elderly care ward where virtually, sort of 95% of the patients were at risk. And I asked them about the screening thing and whether or not they found that annoying that they had to do the screening step. But actually, in reality, if someone is immobile, they just tick one of them boxes and they move straight down. So they're not repeating it really, because you don't have to go, horizontally across the screening. You just go down straight away. So there is no repetitiveness there.
And I think it sort of depends on your, you might make a ward level decision. So the ward that we're asking me were an acute vascular ward. So if they're in a vascular ward, I would say go straight to screening because, they're there because of poor perfusion. They've automatically got a risk condition or else they wouldn't be in. And I think you can make that decision locally. But it's not mandatory to do both. But it is a very small step. And there's been a question about A&E emergency departments using them. And I think, we've really struggled with risk assessment tools in those really busy environments where a large percentage of the patients are not at risk, they're walking wounded. And for me, that's where the screening tool is really beneficial, isn't it?
Yeah, it is. And people do really value that. And people who do work in more acute environments, like on adult surgical wards and things where there's less people at risk, usually they really value the screening because it gives them a little bit of reassurance that actually they have considered the key areas, but they've done it really quickly. And we all know that everybody's got too much to do. So if they can do that, and it just it gives them, I think it reassures them that actually they have considered the necessary things, and they, you know, they screen out then, and it's just a lot quicker for people. But it's not that they've not considered it; it's just that, you know, they've screened them out.
Yeah. There's been a question about one of the common themes that comes up in investigations is around patients' lack of engagement or patients' reluctance to follow preventative strategy, disengagement with those strategies. Would you consider that in future? Is that something that's coming through in literature reviews? I know Lisa Ledger did a very nice piece of work, and I know you two are both involved in a new piece of work looking at how we involve patients in education and how we move that forward. Do you want to say a little bit about that?
Well, I think this is a tricky area, really, because actually I think in reality we don't do that much community. Well, the research I've done anyway suggests that there's not that much communication that goes on between patients and nurses about risk, certainly about risk anyway, before they've actually got a pressure ulcer. In the observational study that I've recently done, I've not really seen people talk to patients about risk that much. And so I think some of it's about just fundamental communication around talking to them about that risk and why people. So sometimes I think nurses and some of the healthcare assistants, I observe them saying, "Oh, we need to keep you moving, we need to keep you moving," but not really explaining why. And so I'm not sure that patients fully understand sometimes if they've never been ill before, and if they've not got, you know, they've not had an issue with pressure ulcer prevention. And Jane, I don't know if you've got anything to say about the severe pressure ulcer work that was done.
Yeah, I mean, I think the severe pressure ulcer work identified failures where there were multiple failures, but patients who had really complex needs were blamed for the development of their pressure ulcers, when actually there should have been an escalated response. So, for example, a patient with a contracture who was blamed for not repositioning, and actually what they needed was the physio to come along and put a bit of foam in between the foot, and the patient was essentially lying on their own foot, so they got a big buttock pressure ulcer. And you know, the healthcare assistants had been telling staff that there was a problem. The qualified staff didn't do anything. Yeah, so I think we have to be quite careful about what we expect patients to do, and the patients that need the biggest input are often those with cognitive problems. So we just can't have that. I think that basic sort of premise is quite difficult, really. Yeah, and there's a couple of other questions that have come up that I know Jackie's got a list and I've got a list as well. So somebody's mentioned MASD, and there's a category of vulnerable skin in the skin assessment section, which is a bit of a catch-all for things that you think might be important. There's a sort of element of clinical judgment in that, but so things like edema, skin irritation of any kind, blanching erythema that's persistent. So things that you think may affect the tolerance of the skin. And from an evidence point of view, it's emerged as actually a risk factor. Defining it is really problematic. So there's an element of clinical judgment in that. So I think that's where you would put that. And then Savita mentioned or asked a question about taking into account the chronic diseases in the elderly. and obviously they've got in care home settings, and obviously many of them have got multi-morbidity. So I think that in that case, most of the patients would, or most of your residents, are likely to emerge as being at risk. But then I think the risk factor profile of the patients and the chronic condition and the chronicity of those conditions informs your clinical judgment and your care planning. So it's not really about the risk assessment, because the key problems are there, you know, undernourished, circulatory problems, immobile, skin condition. So they're the manifestations of those chronic diseases that are important. And I think in the care home setting, you then tailor your provision according to the chronicity and the severity of those problems. But you've also got people in care homes who are often quite stable. So, you know, they're not acutely ill and they have a routine. And if the routine is working for them and they're not going red in any, you know, on any of the pressure areas, then, you know, you're probably doing all of the things that you need to do. And the problem is usually when they become acutely ill and then they become confined to bed when they weren't previously. And then, you know, so it's kicking in at that point that's the flag, is that their situation has changed. Somebody also asked about maternity. Adaptation for maternity, Susanne. I've forgotten whether we did Leeds do something on that.
There was an adaptation that was Mid Yorks that undertook that adaptation for maternity, but again, it's very similar. It's just examples of, I mean, I wasn't sure it was actually necessary. It's just like the examples that are used in the tool. So, you know, and things like, I thought it was more of a training issue really, because obviously, you know, in maternity, if people have epidurals, then that's, you know, something that happens quite frequently and actually could put them at risk of pressure ulcers. And also like the moisture might be different kinds of moisture. So it was just to try and make it more clinically relevant. But the actual risk factors are still very, you know, there's not that much difference really. They're very similar. It's just the examples that are a little bit different.
And did they have a prompt if somebody'd been in labour for so long that was a prompt? I can't remember now.
No, I don't think so.
It wasn't.
I don't think so, but it might have been some adjustment to the mobility bit of it.
Yeah.
In terms of, yeah, there might have been actually. I can't just remember off the. I'd have to look. Yeah.
Susanne, that's a good point about how often would you repeat. So, particularly if you're doing the screening and you're coming out as no risk, how often would you recommend that is redone? So in the NICE guidance, it talks about reassessment being done at any change of condition or any change of environment. Would you say exactly the same, that we don't say in a week, in a month, we say if something changes?
Yeah, I think that's fair enough. I can understand why on a local policy issue people do put timescales in. I think that's more of a safeguard really, so that it does get done and people don't forget, because sometimes as well in practice people's condition can change. If you're in some of the elderly care wards, it might not change massively, but it can change and you've not really picked up on it unless there's a really big change. So I kind of understand why in some of those longer stay environments they say, you know, do a weekly assessment. Some of the more acute environments where like ICU and places like that, I don't really understand that thinking, because most of those patients, well, all of them are at risk by virtue of the fact that they're immobile, unconscious, and, you know, and there might be some variations of that. And then I think that what's really important is you do an initial assessment, but the real thing that's key is you know, the skin assessments then and the ongoing monitoring of the skin, because that's really going to tell you whether or not you need to escalate your interventions or not. And I do think that it's quite good. I think somebody just mentioned about between transfers. I do think that's a good idea to do it on transfer, because I just think for myself as clinically working, you know, it's part of your assessment of that patient. It's kind of part of getting to know them, isn't it? And sort of informing what care you need to provide going forward. So I can see why there's a benefit to doing that. If it prompts the nurse in any way, I can see that that's a useful exercise.
Yeah, and I think one of the things is that we say if a patient moves from a ward to another ward, we should be doing a full skin assessment, and that comes up repeatedly in incident investigations. And the timescales can be quite short. A patient can go from A&E to a ward to theatre back to a different ward. You know, they can go into an assessment ward, go to theatre and finish up on an orthopaedic ward. So they can have 4 assessments within 24 hours.
Yeah.
But actually their risks have changed up and down significantly in those periods. And I think the maternity example is a really good one, isn't it? Because if you have got somebody in labour and you do an assessment when they come in, when they're 12 hours in or 14 hours in and they decide they're going to have an epidural, that risk doesn't it? Skyrockets immediately.
Yeah.
And it's completing the risk assessment hopefully puts it in the midwife's brain.
Yeah. And I think that is like, I mean, you know, one of the things I've found in the research that I've been doing recently is how people like interact with risk assessment tools. And one of the things is, you know, they are like an aid memoir as been traditionally. So it's to help. But if people are in a different environment, like if you work in maternity, then you should be aware that when people have an epidural, it should just be an automatic assumption once you're experienced that actually somebody's going to be more at risk of pressure ulcer development. So when you do your training around the risk assessment, you would tailor it to those kind of things to kind of make it relevant to that area of practice. I think where they are quite useful, these kind of tools, is where, you know, if you're inexperienced, I think they're particularly useful then, because it helps you to guide your decision making, and also gives you a little bit of confidence in what you're doing as well. And also where you might be working in a different care environment, because I think there are, like, there is a bit of tribalism in terms of, for good reason, like on an elderly care ward, you know that a lot of your patients are at risk and you do things automatically. If you were to put a nurse who normally works on elderly care on a surgical ward, for example, it's different, and they don't know that patient population as well, and they can be helpful in that kind of thing as well. Yeah.
I think that's a really good point, Susanne, and I'd put into the chat that we are this year for International Stop the Pressure Day focusing on risk assessment, and lots of the resources we will be doing will be around Purpose T, and we're hoping to run this video again on, I think it's the Wednesday or Thursday, just to flag it up for people. But one of the things we're doing is we're doing some little patient vignettes, to use the word that Jane used earlier, really short videos, 2 to 3 minute videos, where we've got some patients talking about what happened to them, really quick things about why they were at risk. And we have got a lady who was in maternity and had epidural. We have got somebody who was 53 and was diabetic but well controlled, but got necrotizing fasciitis. So went from being what we'd call walking and well to being really quite poorly and got a pressure ulcer. Patient with spinal cord injury, you know, they know all about pressure ulcers, had got all the education, had got his emergency care plan that he'd done with a specialist spinal cord injury nurse, and went into hospital for what he thought was a quick procedure, so didn't take it. You know, it is about that, thinking about if you're in mental health, thinking about if you're in learning disabilities, if you're in maternity or elderly care, what are those things that are pertinent to that? And if you are in maternity and you get a patient with diabetes or something else, do you know enough about that? Do you have to ask?
Yeah.
And we're really trying to flag the risk for patients as well, because one of the really good things for me about the screening tool is the language. It's very simple to explain to patients.
Yeah. I'd like to mention some of the work that we're actually undertaking, which builds on Purpose T. We're doing another study which is looking at developing an intervention for people who live at home with long-term neurological conditions. And it just reminded me of the question that was asked earlier about patient compliance and involvement. Really, what we need to understand is that a lot of the treatments that we put in place and the interventions to prevent pressure ulcers can actually have a massive impact on people's quality of life, and we need to work with them to understand what factors are a problem and what things might help in the real world, in their real life. So we're doing this work, which is just ongoing at the moment, and myself and Delia Muir are leading this work, and we're working with service users to develop an intervention really to help support people at work. And this is something that was suggested by members of our service user group, the person group. They wanted really to have some resource for people to use. So although we're targeting a really specific population, and it's those who actually self-manage the care at home and perhaps don't have people they don't have the district nurses in on a regular basis, so they can slip through the net. But there might be some nice findings from that that might be interesting and applicable to other groups. So it's something that we can keep an eye on and hopefully feed back on.
And they're a really interesting group, aren't they, Susanne? I know when I talk to community teams about patients who develop pressure ulcers when they're not under the care of the community nursing team, or they're seen infrequently, very infrequently by the nursing team, there's always this attempt to allocate, is it in our care? Is it our fault? Who can we blame for this? And how do you blame the patient that if the patient's wife or husband or family were delivering the care? How do you investigate that? And how do you support them going forward?
And I think there's some really interesting things around. So from their point of view, if they're living at home independently, it's like what some of the things that we do are just not acceptable to them, and probably wouldn't be acceptable to us, because we've all got our lives to lead, haven't we? And the quality of life's really important. So it's about kind of understanding them. And then I think in clinical practice, the issue that we've got is that often we've got competing demands in terms of managing different risks. And I'm mindful of that more so now than ever after doing some of the observational work I've done, where you have competing risks. So, patients who might have had a stroke and need to sit out to improve the sitting balance and build that up, and yet have a pressure ulcer. And so there's like these conflicting things. And this is where the expertise of the nurse and the use of clinical judgment is really important in trying to get in place an appropriate plan of care that kind of meets the needs of that particular patient, which are often complex. And it's not, you're not just looking after pressure areas, you are looking at it in the context of they might have 15 assessments and other care plans that they've got going on as well in these people with complex.
And some from non-nurses, you talked about sitting balance. That's often an interdisciplinary activity, isn't it? And it is about making sure we engage our non-nursing colleagues in understanding what our priorities are, we understand theirs, and that we develop collaborative plans of care, so that we're not, we're saying keep moving, they're saying keep still, or whatever it may be. It's the same as the leg walls, for example, where one nurse says you must sit with your leg up and the other nurse says you must keep moving. Both are kind of right, but nobody told them when to apply those two things.
It's about having that holistic approach, isn't it? And being able to manage the plan throughout, so you get a bit of everything. So that also that, it's not good for people to be laid in bed all the time, chest infections and all the rest of it. So, but equally, sitting on a pressure ulcer for a long period of time is not good. And I think there is something around teamwork and working with people so that you plan that patient's day. I know it's really difficult because it's chaotic, but I did see some good examples of that actually, where physios did some work with the patient and said, they talked to the nurses about that, and the nurses talked to them about how long they could be out for, and they agreed to come back and do the next things when they were going back to bed, and that, like helping each other out really to try and manage the patient's care in a sort of coordinated way. I also observed things where that wasn't the case, but there are there's good and it's just about trying to kind of make it more good, isn't it? And facilitate that team working that helps sort of provide that holistic care.
And I think that was one of the benefits we saw during COVID, wasn't it? We saw the therapy teams working much more closely with the nursing teams, because there's nothing more frustrating than you've just got a patient clean, back into bed, comfortable, repositioned, and the physio turns up to get them out again. And they got very engaged in that. And exactly as you described, talking about what was the convenient time, where did it fit in the patient's day, you know, how do we build that into an overall plan of care? And going back to the point we talked about earlier about, do patients engage in their plan of care? It's not surprising sometimes if they've got one person telling them to do this and another one telling them to do something completely different, that they disengage from it and they don't trust anybody. And I think for a lot of patients and their families, there is a really strong element of they need to trust the clinician to follow the care. And if they lose that trust, then they do disengage.
Yeah, no, I think you're right.
I'm just quickly skimming through the questions. I'm seeing quite a few people are needing to leave. Go on, Suzanne, what did you see?
Somebody wanted to know what Purpose T stands for.
I dropped in off the website.
So I'm going to tell you, but you'll forget. In fact, I might forget. Let's see if I can remember. So it's pressure ulcer risk, primary or secondary evaluation tool. So, and the reason why we came up with that is because the actual program of research that Jane was the chief investigator for was called the Purpose Program. So we did try and really make it fit because we thought it was nice. And also it was in recognition of the fact that there was a real team effort in pulling together and developing the tool. And so we decided against going down the Nixon Coleman or Coleman Nixon tool. We kind of decided against that. So
are there any more questions? I think there's been a few comments, lots of statements, lots of sharing of email addresses, some talk about heels in specific, getting podiatry involved in that, but I think that comes under AHPs. Jane, have you seen anything else? Have we missed anything?
No, I haven't seen anything else.
So can I then bring this to a conclusion? Can I thank both Susanne and Jane for their input? I think it's been really useful. I know a lot of you have said how helpful you found this, and it is great to hear it from the people who made the tool so you can actually ask them and get the correct answers. A reminder that we've got International Stop the Pressure Day on November the 17th this year. I have put the link up for our work with the Society of Tissue Viability. I'll put it back in again if I can. Just to say, we will be putting out an awful lot of resources around risk assessment. There'll be resources for clinicians, resources for education, and resources for patients. We will be doing a We Nurses tweet takeover. We'll be running webinars. We'll be doing some nice videos, and we will be doing a series of short videos talking about the different elements of the Purpose T. So if you want to find more information, do go to that link on the Society of Tissue Viability website. And thank you again for your attendance. We hope you've enjoyed it as much as we did. Thank you.
Before you go, can I just shamelessly as well say that the EPUAP conference next year is going to be held in Leeds, and I'm the chair of the organising committee, and Jane and Jackie are going to be involved in that as well. And one of our themes will be around, it's September the I'll tweet about it nearer the time. I think it's the 12th actually, or something like that. But yeah, it's at the Royal Armouries in Leeds, so I hope you can all join that. There'll be advertisements coming out soon, no doubt.
I'm just trying to quickly skip through my calendar, Suzanne. I'm not that quick. I just got to October.
Sorry. I've got it in mine as well.
So yes, thank you everybody.
Yeah.
And remember, the webinar will be recorded and put up for you to view. Thank you everybody.